Hello, everyone, and welcome to today's webinar, Role of Serology for Congenital Infections and Vaccine-Preventable Diseases in the Prenatal Setting. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Bio-Rad Laboratories. To learn more, visit bio-rad.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. So I'd now like to welcome our speakers. Dr. Alan Wu, Professor, Lab Medicine, University of California, San Francisco, Co-Core Lab Director, Zuckerberg San Francisco General Hospital, and Dr. Russell Neuner, Research and Development Manager at Bio-Rad Laboratories. Dr. Wu, I'll pass it over. You may now begin your presentation.
Welcome to the next webinar sponsored by LabRoots. Today's topic is the laboratory's role in preventing prenatal infections. My name is Alan Wu, and I'm from the University of California, San Francisco, and the Zuckerberg San Francisco General Hospital. Let's start off with some statistics. On this slide, I show pregnancy outcomes during intrauterine infections. Among stillborn births, about 10 to 30% of cases have some infectious disease etiology. Among live births, about 3% have some congenital anomaly, and the fetal death rate ranges from 3% for pyrovirus B19 to as much as 50% for T. pallidum, the infectious agent that causes syphilis. Laboratory testing has been defined by this acronym, TORCH, first coined in 1971 by Dr. Andre Namias of Emory University. T stands for toxoplasmosis. O is kind of a catch-all. It includes other infections that might be syphilis, HIV, hepatitis, varicella, and parvovirus. R stands for rubella. C stands for cytomegalovirus, and H is herpes simplex. Vulnerable populations for these infections includes those who are immunocompromised, such as those with HIV, transplant recipients, the elderly, and the infants. And particularly relevant for this talk are the vulnerability of fetuses during the prenatal period. About a dozen years ago, there was a survey conducted of obstetricians' knowledge of prenatal infections. And most of these doctors understood that their patients should avoid cleaning litter boxes, cook meat until they're well done, get tested for HIV, avoid contact with people who have been infected, keeping up to date with vaccines, hand washing, and avoid exposures to wild or pet rodents. Lesser known was not sharing utensils with toddlers, not getting babies' saliva into eyes and mouths, and this one I didn't know about. They should be avoiding licking envelopes. The other questions asked in the survey was the percentage of respondents who counsel patients about how and why to prevent infections. And these are the target infections that they counsel their patients on. And you can see here that many of these infections are included within the TORCH panel. I want to now start talking about specific microorganisms that can produce congenital infections. In each of these next slides, I'll first talk about the route of administration, the pathophysiologic effects that these infections have on the neonates, and the current status of vaccines. Let's start with Toxoplasma gondii. This is an intracellular protozoan. It has been said to be the most successful parasite in the world today, with about 30% of the population infected. The parasite is shown in below. The definitive host is the domestic cat. Cats excrete into their feces oocytes that become sporulated and then can transmit into intermediate hosts through the food supply, water supply, and exposure to soil. In the pregnant woman, infected uncooked meat from these secondary hosts can lead to a toxoplasma infection. These infections then can transmit through the placenta into the unborn fetus. This slide shows the clinical presentation of congenital toxoplasmosis. The most notable effects are in the brain. This includes the presentation of hydrocephalus, microcephaly, which is a smaller than unusual size of the head, encephalopathy, each of these leading to mental retardation. Infants may be asymptomatic at birth, but during their childhood, they can develop these problems. PCR is used to confirm the diagnosis in neonates. Also, toxoplasma antibodies, particularly IgG, is used to determine negativity or disappearance on serial testing as a means to exclude congenital infections. This is the release pattern of toxoplasmosis antibodies over time. You can see here that within a few weeks of infection, there is the release of the IgM antibody that over the course of several months seroconverts to IgG. There is a time when both of these antibodies are present. Over time, eventually, the IgG becomes the predominant form and the levels of IgM decline. This can be very useful in pinpointing the time of infection, because if a mother is infected actively during pregnancy, this is a most dangerous time for that child. One of the tests that can be used to determine the temporal relationship of antibodies, in addition to the relative levels of IgG and IgM, is a test known as IgG avidity. The avidity of an antibody is described as how tightly bound is the antibody to its antigen. And there are avidity tests available for circulating antibodies. An antibody that has low avidity, as shown in the top part of the slide, can be displaced with urea. Antibodies that have high avidity are resistant to displacement with urea. This slide goes over the interpretation of toxoplasma serology. When they're both negative, clear that it indicates no past or recent infection. When the IgG is positive, it indicates immunity to toxoplasmosis and subsequent pregnancies are safe. When the IgM is alone positive, this would indicate very early positive infection, or it's a potential for a false positive result. Nevertheless, testing should be repeated in 2 to 4 weeks to see if there is IgG seroconversion. When they're both positive, this is suggestive of an acute infection. The IgG avidity test can help us confirm this notion. When low, it indicates that this is in fact a recent infection and requires treatment to avoid congenital toxoplasmosis. However, if the avidity is high, even with the presence of IgM antibodies, it indicates an infection out by at least 4 months, and a pregnancy is safe and no treatment is necessary. There are no toxoplasma vaccines available to date. This is a recent paper published last year that looks at live attenuated virus against research mice strains, the WH3 and WH6 strains. And you can see here in red unvaccinated individuals, and the percent survival is very low as opposed to mice that have been vaccinated with these two live viruses, showing tremendous improvement. I'm hopeful that we can achieve a toxoplasma vaccines sometime in the next few years. Okay, so let's move on to German measles. German measles is also known as rubella. It can be transmitted via respiratory droplets in the similar manner as SARS-CoV-2. In the pregnant female, the virus can be transmitted through the placenta and onto the growing fetus and into a newborn. This is the clinical manifestations of congenital rubella, similar to what we saw with toxoplasmosis. You see the microcephaly, you see the encephalitis, you can see hearing loss. There is, in addition, congenital heart disease, bone disease, purpura, and thrombocytopenia. The purpura is the presence of these blood underneath the skin due to damaged blood vessels. Not to confuse German measles with measles, which is paramyxoviridae, and chickenpox, which is varicella zoster. All three of these conditions produce a skin-like lesions known as pox, but upon closer examination, there is a differentiation in the morphology of these pox, and therefore indicative of different disease etiologies. There has been a rubella vaccine available for many decades. Here are some data prior to the vaccine that was created in 1964 and 1965, for where there are over 12 million cases of rubella and many thousands of cases of congenital rubella syndrome, resulting in many infants who became deaf, blind, intellectually disabled, and resulting in a number of neonatal deaths. It also led to a number of abortions, both a combination of elective, when the parents found out that there was a rubella infection, or spontaneous. In 1969, a live attenuated virus was released, and a couple of years later, it was put into combination with the measles, mumps, and rubella vaccine, the so-called MMR vaccine. Today, Centers for Disease Control recommend children get 2 doses of this vaccine, one within the first year of birth, and a second one at 4 to 6 years of life. As a result of this rubella vaccine, similar to the success story with polio, we have largely eradicated rubella in the United States, and most people have positive antibodies. There are a number of countries for which rubella continues to be endemic. Those countries are listed in this slide. If you practice in a location in the US that has a lot of foreign travelers from these countries, this test becomes important, especially for pregnant women. The next on our list is CMV, or cytomegalovirus. As shown in this slide, the route of administration is quite diverse. In addition to respiratory droplets as seen through coughing or sneezing, there can be oral transmission through oral fluids, blood transfusions, sexual contact, contact with infected urine and feces, transplantation of organs, and vertical transmission either through the placenta or through breast milk. When a fetus and newborn suffers from congenital CMV infection, these are the clinical manifestations. Again, very similar to some of these other infections, microcephaly in about half of the cases. There can be hearing loss in about a third, thrombocytopenia, low platelet count, chorioretinitis, hepatomegaly with increased liver function tests, and sphingomagaly, and in particular, intrauterine growth restriction, which is IUGR, about 40% of cases. This is characterized by poor growth rate in utero. None of these things are favorable. Despite decades of effort, there are currently no CMV vaccines available today. CMV was discovered in 1956 by the same research team that discovered polio, mumps, and rubella. The first attempts at a vaccine was published in 1984. In the year 2000, there was an economic report conducted in the US that concluded that a CMV vaccine would be highly cost-effective. We'll be talking about cost-effectiveness of testing later in this presentation. In 2009 to 2012, there were some promising results for two different types of CMV vaccines. However, neither one of them reached FDA clearance. And despite the fact that we have vaccines for polio, measles, mumps, and rubella, CMV has been left behind. And in this sort of tongue-in-cheek slide, the author said, can we get a vaccine to pension CMV before it reaches the age of 65? Let's move on now to HSV, or herpes simplex virus. This slide shows the route of neonatal exposure. HSV is transmitted through sexual intercourse. It starts with an infection present in male genitalia in the form of chancres, which then gets transmitted to female genitalia, which then transmits in utero to neonates, and with a 20 to 50% risk of transmission. The clinical manifestations of neonatal herpes is shown here. There can be central nervous system involvement, there can be skin lesions, and mucous membrane involvement. The presentation includes encephalitis, respiratory failure, hepatic failure, DIC, can lead to seizures, lethargy, irritability, feeding problems, temperature instability with rash, and the mortality can in fact be fairly significant. We don't have a herpes vaccine at the moment, but I am encouraged by this note that was published a couple of months ago. The company BioNTech has dosed its first patients in clinical trials for their vaccine. Zika is not part of the O in the torch panel, but I thought I would talk about it. The mode of transmission is through the mosquito. The mosquito bites a male, which can then, through sexual intercourse, transmit the infection to a pregnant woman, who can then transmit it to the fetus and neonate, either through intrauterine transfer to form congenital Zika or through postpartum transmission via breast milk. The virus is present in both placental cells and amniotic fluid, amongst other body fluids. The clinical manifestations include fetal loss, congenital Zika syndromes with microcephaly in a minority of cases. The majority of cases are, in fact, either asymptomatic or unaffected. So the rate of transmission is only 20 to 30%. There are no Zika vaccines available, but there are some experimental reports. This one was published 6 months ago, looking at a experimental vaccine developed in mice. Slide A shows immunization with the vaccine, a booster injection 2 weeks later, then challenging the mice with the virus, doing blood testing, and then determining efficacy. You can see here in the preliminary data that individual mice who are treated with the vaccine did better than those who were unvaccinated. This was an interesting headline that I found in one of the vaccine tabloids entitled "Massive Zika Vaccine Trial Struggles as Researchers Revive a Plan to Intentionally Infect Humans." The disappearance of Zika in the Americas, predominantly South and Central America, is making it difficult to conduct these vaccine trials. And so what is considered is infecting individuals with vaccine and then seeing if they can be treated. Now let's talk about strategies for torch antibody testing. Bedside testing is available using lateral flow point-of-care devices that are multiplexed and enables you to simultaneously measure each of the 5 members of the panel. These are designed for individual patients. They're not really amenable to high volume testing situations. And sometimes these endpoints on lateral flow can be ambiguous. The central laboratory uses instruments where individual immunoassays are available, 1 assay per channel. It's very useful in reference laboratories that have a high volume of samples. However, for a hospital-based laboratory, you may not want to consume that many channels for immunoassay antibody testing. A third approach would be to use a multiplexed bead assay, such as what's shown here, the BioPlex 2200. It does allow you to put together other panels without consuming a lot of reagent space. The individual tests, however, have to be validated to ensure that there's no crosstalk between antibodies. And the next lecture in this webinar will describe the steps that Bio-Rad has taken in constructing this assay. I would like to conclude my webinar by discussing some medical economics for torch testing. Can we justify screening tests for pregnant women? Medical economists use something called the quality adjusted life year as a metric to determine the effectiveness of some type of intervention, whether it be treatment, surgery, or pharmacology. As shown in this slide here, without that treatment, there can be a certain life expectancy that is improved with the initiation of treatment. The gap between these two curves is known as the QALY gain. Now, this can be quantified in dollar amounts simply as the incremental cost effectiveness ratio, or ICER. It is the cost of the experimental procedure minus the cost of the control divided by the QALY of the experiment minus that of the control. This slide shows the cost effectiveness for other types of interventions and comparing that to prenatal screening. So for colorectal screening using occult blood, it's $3,000 per live saved per year. Cholesterol screening, $6,000. Mammography screening for breast cancer, about $19,000. As you can see here, triple marker testing as well as prenatal toxoplasmosis testing is roughly around those limits. Now, what is the threshold for acceptability? What is the willingness to pay for such interventions? It is typically somewhere between $50,000 and $100,000 per life saved. Under this metric, the prenatal testing for infectious disease, which is something that we're not doing, can be justified. The CPT code for torch tests from using 2019 prices are shown here. Note that there is no torch panel, that the individual tests are separately reimbursed as listed here, roughly about $16 to $21. In conclusion, serology tests are widely available for diagnosing torch infections. Despite the significant medical effects of congenital infections, prenatal screening has not been endorsed by clinical practice groups. This is despite the fact that cost analysis suggests that screening is economically justifiable. I want to thank you for tuning in to this webinar, and I would like to thank LabRoots for hosting this platform.
Great, thank you, Dr. Wu. I'd like to now pass it over to Dr. Neuner.
Hello, my name is Russell Neuner, and I am a R&D manager in the Clinical Immunology group at Bio-Rad. Today I will be speaking with you about the laboratory role in containing vaccine-preventable diseases, with a primary focus on the MMRV vaccine. MMRV is an acronym that stands for 4 different viral diseases: measles, mumps, rubella, also known as German measles, and varicella-zoster. All 4 diseases are present worldwide and are preventable through a full-dose vaccination program. Children typically receive a 2-dose vaccine between the ages of 1 and 5 years of age. Healthcare workers, due to their high risk on the job, should be immune to these infectious agents. Diagnostic testing can be used to determine serological status, and a comprehensive determination of serological status provides the opportunity to reduce the spread of these highly contagious diseases. Measles is a disease that is transmitted through respiratory secretions or directly from person to person. The incubation period is between 10 to 12 days, with a skin rash occurring approximately 14 days after exposure. Symptoms can also be severe, ranging from diarrhea, ear infections, or bronchopneumonia. In developing countries, the fatality rate can be up to 25%, caused by acute encephalitis. Mumps is a disease that is transmitted through respiratory secretions or directly from person to person. The incubation period is between 16 to 18 days, with classical symptoms presenting as bilateral parotitis, fever, headache, or malaise. Children typically do not develop severe symptoms. However, it is becoming more common that teenage boys and men develop infertility or subfertility. Perinatal mumps remain rare. Rubella is a disease that is transmitted through respiratory secretions or directly from person to person. It is caused by the rubivirus and is predominantly asymptomatic in the majority of infected people. However, when symptomatic, it presents as a low-grade fever, headache, sore throat, or skin rash. Rubella can have severe consequences during pregnancy, resulting in miscarriage, stillbirth, or fetal anomalies. And presently, to date, there is no antiviral treatment for rubella. Varicella zoster, or VZV, is a disease that is transmitted through respiratory secretions or directly from person to person. It is a highly contagious disease and is most commonly known as chickenpox. The incubation period is between 10 to 21 days, with the most common symptom being a skin rash. A systematic infection usually results in lifetime immunity. Severe symptoms can be in adults and in the immunocompromised. The VZV virus can also remain dormant in sensory nerve ganglia until later in life, where reactivation can cause herpes zoster, or more commonly known as shingles. So why should we test for MMRV antibodies such as IgG? Understanding a person's immune status provides the opportunity to reduce the spread of highly contagious diseases. This is especially important as these diseases can be prevented through a full-dose vaccination program or booster vaccine. IgG serology screening is a valuable tool in preventing prenatal infections by identifying maternal immune status. In addition, IgG testing is useful for pre-employment screening, such as healthcare or military workers, to prevent unnecessary vaccinations when immune status is unknown. Despite the tremendous progress made by worldwide vaccination programs, measles remains a public health problem in Europe. In 2018 alone, more than 21,000 cases were reported. This was the highest number of cases in the past decade and was 3 times the total number of measles cases in 2017. There are indications that a further 300% increase is expected in more recent years. After a 2-dose vaccine regimen, the efficacy rates for MMRV all remain very high, ranging from 96% to 99%. MMRV is largely eradicated in the US. However, there have been recent measles outbreaks reported. The outbreaks have been due to unvaccinated children and adults who experience waning immunity over a long period of time. Vaccine-preventable diseases have been re-emerging despite sustained high vaccine coverage. As shown in the figure on the right, before vaccination, highly contagious diseases such as measles and mumps were common in young children and the incidence of disease was high. Upon natural infection, a person's antibody titer level elevated, and then throughout life, repeat exposures and infections from community outbreaks served as natural boosting events which help to retain a person's antibody titer level. Now, in the vaccine era, after a 2-dose vaccination, a person's antibody level becomes elevated. However, in the absence of community outbreaks, there are no opportunities for natural boosting. Therefore, vaccine-induced immunity may wane more rapidly compared to immunity from a natural infection. This, however, may differ depending on the target disease and certainly each person's immune system. An example of this is mumps reemergence appears linked to waning vaccine immunity, also known as secondary vaccine failures. However, for measles, outbreaks remain concentrated in areas of poor vaccination rates, and the role of waning immunity is unclear. To conclude this study, further research incorporating immunological and epidemiological data are critical to determine the best path for preventing the reemergence of vaccine-preventable diseases. In our next section, I will be discussing how to improve workflow efficiencies in infectious disease prenatal settings by showcasing the BioPlex 2200 system solution. As Dr. Wu mentioned in his presentation, torch testing is a high priority for testing during the prenatal period. Prenatal testing for torch is used to determine exposure to infectious agents that can cause congenital diseases. The BioPlex 2200 system offers novel multiplex panels to simultaneously identify and differentiate antibodies for these infectious diseases. Here at Bio-Rad, we offer 3 infectious disease panel products on our BioPlex 2200 system. The first 2 are TORC, IgG, and IgM panels for detection of antibodies to Toxoplasma gondii, rubella, and cytomegalovirus. The second is HSV IgG panel for detection of antibodies to HSV1 and HSV2. In addition, we offer a MMRV IgG panel for detection of antibodies to measles, mumps, rubella, and VZV. This product provides a solution for streamlined assessment of vaccine-preventable diseases to determine if a vaccine or booster is recommended. The design of the BioPlex MMRV IgG product offers many workflow advantages to our customers. In traditional testing, a patient sample is consumed by 4 independent single analyte tests. In the case of MMRV, this is a single test for measles, a single test for mumps, a single test for rubella, and a single test for VZV. So traditional testing provides 4 separate test results to the clinician. In BioPlex 2200 testing, the system uses the power of multiplexing technology to consume a patient sample in a single test. This improved workflow provides 4 test results to the clinician and up to 400 test results per hour. By harnessing the power of multiplexing with the BioPlex 2200 system, a clinician can receive multiple results from a single test. This technology uses small microsphere beads that contain multiple fluorescently dyed barcodes. Each unique barcoded bead is labeled with a different disease-specific antigen. For example, in the BioPlex MMRV IgG panel, there are 4 individual assay beads, 1 for measles, 1 for mumps, 1 for rubella, and a 4th for VZV, together with 3 quality control beads that are mixed and combined together to create the MMRV IgG assay. The BioPlex 2200 system improves result throughput and turnaround time by generating multiple results in a single test. It eliminates time-consuming sample and reagent preparations, dramatically reduces sample volume requirements, which all help to lower overall costs and labor. BioPlex panel design starts with the selection of high-quality antigen biomarkers. For the MMRV IgG panel, this included screening recombinant viral antigens to identify the presence of IgG class antibodies associated with measles, mumps, rubella, and VZV. 3 additional dyed beads are mixed and combined in the assay, and they serve as internal quality control beads to verify detector response, to verify the addition of serum or plasma sample, and to verify the absence of significant non-specific binding in the assay. During assay optimization, our team develops the heterogeneous assay format, which includes the assay protocol. Singleplex versus multiplex analytical and clinical performance is confirmed, as well as extensive cross-reactivity testing that helps to reduce non-specific binding and alleviate assay interferences. In addition, extensive verification and validation testing is performed according to the Clinical and Laboratory Standards Institute guidelines. These studies include precision between lab reproducibility, assay linearity for quantitative assays, interference, limit of detection, and reagent calibrator and control stability. Every BioPlex product undergoes multiple quality control procedures throughout the entire manufacturing process, from raw material to formulation to component and final kitting. Each bead is manufactured and QC'd individually, and then further tested in a multiplex assay format prior to final kit release. Each panel contains internal assay QC beads that help verify assay performance. Overall, our QC procedures help to minimize lot-to-lot variation and create a high-quality product. To summarize, the BioPlex 2200 system is a fully automated, random access, easy-to-use diagnostic testing platform. It uses primary tube sampling and only 5 microliter sample volume for the MMRV panel. It has electronic reflex test add-on capability and is compatible with the majority of laboratory automated track lines. BioPlex panel products are high throughput and with up to 400 tests per hour for the MMRV panel. The diagram shown on the right shows the entire infectious disease product portfolio that is currently available for the BioPlex 2200 system. And lastly, at Bio-Rad, quality is at the heart of everything we do and is integral to our guiding principles and core values. I would like to thank you for attending today's webinar, sponsored by LabRoots.
Well, thank you, Dr. Wu and Dr. Neuner, for your informative presentations. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. So let's get started. We've got some great questions coming in from our audience here. So I have a first question here directed towards Dr. Neuner. And this question asks, what is the difference between determining serological status and immune status?
So the FDA defines serological status as the detection of IgG or IgM antibodies, while the immune status is defined as the detection of both IgG and IgM antibodies. So in terms of the clinical perspective, knowing the immune status can inform clinicians that a patient has sufficient antibodies to consider themselves immune or protected against a disease. For serological status, though, if a patient is negative, this means no antibodies are detected. And therefore, the patient is either unvaccinated or has never been exposed to a disease, or possibly has waning antibodies that fell below the limit of detection of the assay used. If a patient is positive, this means antibodies are detected and the patient is likely protected against the disease.
Great, thank you. My next question here is for Dr. Wu, and this question asks, I notice these assays are not recommended or included in the guidelines.
Yeah, I think that's something that needs to be addressed. There has to be key opinion leaders who write these guidelines and get together and say this is both medically and economically useful, particularly for the neonate. And I think the time now is ripe because we do have these assays that are multiplexed and are high volume, but it does require people to make that a priority within their professional groups. And right now, I don't see that happening, and not sure how to make it happen.
Great, thank you, Dr. Wu. I have another question for you here, and this one asks, you mentioned that there are vaccines in development for several congenital infections. Do you see the landscape for diagnostic testing changing with the introduction of new vaccines, for example, CMV?
Yes, in a similar way that we have tested individuals who have been vaccinated with COVID just to ensure that antibodies have been produced and that the person is safe, that we should expect to see some of that following some of the newer virus vaccines that we hope will show up in the future. In terms of testing everybody routinely, we don't do that now for COVID. The CDC says only in high-risk groups would that make sense. And I suspect that that will be the case with some of these other virus vaccines.
Great. Dr. Neuner, I have another question for you here, and this one asks, why do you think we are seeing outbreaks today in the world of vaccination?
This is a great question, and I'd like to use measles as an example. I think what we are seeing now, for possibly the first time ever in the history of vaccinations, is the majority of adults have never had a natural measles exposure. Vaccine immune waning is an important contributor to the cause of outbreaks, and it is only now that these effects are being revealed. However, it's important to remain vigilant and keep an open mind when recognizing secondary vaccine failures if and when they occur.
Great. All right, I have another question for you, Dr. Neuner, and this question asks, does Bio-Rad offer as well a MMRV IgM kit?
Yes, we do, and it is also commercially available on our website.
Great. All right, another question here for Dr. Wu. This question asks, many current guidelines and recommendations have removed routine screening of pregnant persons for HSV. Can you speak to this?
Yeah, I'm disappointed with that I don't think that is a good move. I think that should stay in there. Perhaps it was removed because the incidence of congenital herpes was not high, and again, it's all a matter of economic justification. I showed in my slide that clearly toxoplasmosis is economically viable for screening, but we haven't seen the same thing for herpes.
Great. Well, we are going to conclude our session there today. So, Dr. Neuner, Dr. Wu, do you have any final comments for our audience?
Well, I just want to say to everybody who's listening to, stay vigilant and try to maintain good infection control practices. We that work in the clinical laboratory, as well as people at industry who are exposed to specimens, are at higher risk, and that when vaccines do become available, such as in COVID, that you embrace them.
And I would echo Dr. Wu's sentiment as well. And I just want to say thank you to everyone that attended, and also a thank you to our sponsor, LabRoots, for today's webinar.
Great. Well, thank you again, Dr. Wu and Dr. Neuner, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Bio-Rad Laboratories, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.